Hi everyone, and welcome to Exploring Health, Macro to Micro. I'm your host, Parker Condit. In the show, I interview health and wellness experts, and by the end of each episode, you'll have concrete, tangible advice that you can start implementing today to start living a healthier life, either for yourself or for your loved ones. And that's the micro side of the show. The macro side of the show is discussing larger systemic issues that are contributing to health outcomes here in the US. So an example of that, probably the most obvious example of that, is understanding that our system is largely reactive and most money goes towards fixing health problems and there's almost no money that goes towards prevention. And that's something we discuss in today's show. My guest today is Dr. Doug Lucas. Dr. Doug is the founder and CEO of Optimal Bone Health in Asheville, North Carolina. He's a board-certified anti-aging and regenerative medicine physician. He's also a board-certified orthopedic surgeon. So as a former surgeon, he said that he ended up starting his own company with the goal of teaching patients so they could avoid the types of surgeries that he was actually trained to perform. So in this episode, we have a central theme of bone health. As an orthopedic surgeon, makes sense. We end up talking about why bone health needs a new PR firm, and that'll make sense within the first minute of this episode. We talk osteoporosis and osteopenia, the difference between them, how they're measured and how they're diagnosed. Dr. Doug goes over his pillars of health, exercise, nutrition, sleep, and connection. He discusses how men and women differ when it comes to bone health and preventative measures. And we also get into how patients can be their own best advocates in a healthcare system that does not put patients at the center of care. So if you're interested in longevity or if you have aging parents, this is a very important episode to listen to. Bone health does not get nearly the attention that it deserves, but this conversation will hopefully bring a few important points and topics to the front of mind for many of you. So that's enough of me talking. Let's just get to it. Please enjoy my conversation with Dr. Doug Lucas. Dr. Doug Lucas, let's just start with some of the basics around osteoporosis. I think it's going to be helpful for people to understand what it is, some basic stats around it, basically getting people invested in like why should people care about this? I think everyone's pretty bought in on heart disease, everyone's bought in on cancer, but I'd love for you just to explain what you can around osteoporosis.
Yeah, well, thanks so much for having me and being able to talk about this topic because you just actually nailed it. So there's so much conversation around heart disease and around cancer and around dementia, and there absolutely should be. But in those top 4 killers of us as adults as we age is falls from osteoporosis. It's right in there with them, and yet almost no conversation, right? It's like it's absent from the communication. And I think it's sad because it is absolutely preventable for the vast majority of people. Arguably, so is heart disease, but yet. The statistics are scary. And when I talk about, who is likely to have a fracture, that is a big group of people. So we're talking 50% of women and 25% of men will have a fragility fracture, which is the fracture that happens with osteoporosis in their lifetime. So that's a huge number. And people could argue, oh, well, that's, when we're 90 years old. But no, it really starts early on, really in your 60s and even in your 50s for some. And some of those fractures, like hip fractures, have so much morbidity associated with them, meaning that people don't do well. A third of people with hip fractures die. A third of people never regain independence. Only a third of people even get back to the living situation that they were in. And even then, they're not the same. So being able to prevent these things and having a plan around, how to deal with this for the rest of your aging life is really important.
Yeah. I think I was so curious to talk to you and excited to have the opportunity to talk to you because I read something a few weeks ago. I saw it on Instagram, but maybe you can confirm this, but it was an alarming number. It was that anyone who has a hip fracture who's over 65, there's a 15 to 30% chance they will die within the next 12 months.
Right.
Like,
it's absolutely true.
That's alarming. And like you said, most people don't talk about this, and maybe it's because I'm 34, but I feel like I'm relatively well plugged into the health space. And it seems like the osteoporosis and like the bone health and bone density PR firms aren't doing what cancer's doing out there. It just seems like it's just not getting that sort of attention.
No, and the truth is, there's cancer is a really tough problem. Not to downplay cancer,
right?
But the truth is, bone health, it's actually a pretty simple problem that there just isn't much funding behind. So if you look at the government agencies that have the ability to do the megaphone communication, they just don't have the resources.
Oh,
And so it's just a really under-discussed issue that really has a pretty simple solution.
okay. We're going to get to solutions at some point, certainly, but I'd love to be able to discuss kind of the implications and the differences between men and women, because I had a women's health expert on a few weeks ago, so that was a very interesting conversation. Are there differences between men and women as far as like risk factors, when you need to start caring, things like that?
Yeah, so if you look just statistically, women suffer from this earlier than men, and there are some numerous reasons why you could argue, but the biggest one is that women go through menopause at a relatively predictable time, even though it's a range. Men go through andropause, which is the loss of the male sex hormones, at a much slower pace, right? So like men will go through andropause for decades, and depending on their starting point, they're not going to have issues with loss of sex hormones until much later in life. Whereas women, when they go through menopause, it's like, boom, it's over. And so they suffer the loss of estrogen, testosterone, and progesterone, and all three sex hormones play a role in bone metabolism. So depending on their starting point, we see a lot of women who are perimenopausal and early postmenopausal who already have osteoporosis. So it's a bigger deal for them much earlier on. And that's the big difference between men and women. Also, men generally have a higher starting point when it comes to just bone mineral density. And we can talk about whether, what that means and why it's important or not. But they have a better starting point as far as fracture risk goes. So they're also less likely to suffer a fracture earlier in life, but this does become an issue for them later in life.
Okay. This is me going off cue already. So you said suffering a fracture earlier in life. If you suffer a fracture earlier in life, are you at a higher likelihood for a repeat fracture?
Absolutely. Yeah. I mean, the biggest risk factor for a fragility fracture is a previous fragility fracture.
Okay. Interesting. So this is kind of piggybacking off of what I learned about the Women's Health Initiative and sort of the resulting effects of that, of hormone replacement therapy basically stopping in 2002 or right around 2002. Can hormone replacement therapy help with osteoporosis and help sort of, you were talking about like the very precipitous decline. Can this sort of ease that and help with bone density for women?
Yeah. So I'll choose my words super carefully in case the FTC is listening. So hormone therapy as a whole is not FDA approved for osteoporosis, although estrogen or estradiol therapy is alone, although you can argue why. But estrogen and progesterone and testosterone, the whole package, if that's what you're using in a bioidentical perspective, is not FDA approved for osteoporosis. As I mentioned earlier, though, each of those hormones plays a different role in bone metabolism. So estrogen will slow down osteoclasts. Those are the cells that break down bone. It'll slow down osteoclast function. So maintaining estrogen after menopause through hormone replacement will slow down bone loss, undeniably. It was used as the primary tool for osteoporosis for decades prior to the Women's Health Initiative. Progesterone also plays a role in osteoblasts. That's the cells that make bone. So osteoblasts, both function and differentiation, meaning like from stem cells to become osteoblasts. And then testosterone, somewhat directly on bone, but more indirectly through muscle mass. We know that sarcopenia, or loss of muscle mass as we age, is strongly associated with bone health. You could almost argue like chicken or the egg. But testosterone has such an impact on muscle mass that will obviously have an impact on bone health too.
Okay. Yeah, I appreciate you kind of being able to dive into that. And it's funny how a lot of these conversations are now dovetailing largely towards the same things. So I guess from there is, can you start discussing some of the lifestyle factors that are associated with this, and maybe also diving into you rattled off some ages earlier, 50s, 60s. Obviously, if you're there already, it's not too late, right? Like you can always do stuff to mitigate future risk. But when should be, like in an optimal scenario, when should people start being proactive about bone health?
Yeah, so I get this question a lot, and people look at me funny when I answer, but honestly, the time to start knowing where your bone density is in your early, 20s and 30s, your early adulthood. And the reason for that is we reach peak bone mass at that age. So if you know that you don't have good bone mass, like for example, I was osteopenic in my 20s, and it's because I had a crappy diet growing up. And so I know that I have osteopenia. Now I also know that my bone mass hasn't changed over the last 30 years. But I knew what my starting point was. And it's because I was a research subject in my wife's PhD thesis. But if you know that you have a low starting point, then you know that you need to be much more careful about things that affect your bone over time. Should you take those steroids or not? Should you go on a PPI or not? Should you be on, some kind of a supplement to help to metabolize bone? Should you take a birth control pill? No. Like all those things. And so you can know where your starting point is earlier on, you're going to be better off. So realistically though, most of the people listening to this, if they saw osteoporosis in the title, they're going to be probably in their 40s, 50s or beyond. So when does that group get a DEXA scan? And my response would be, if you haven't had one, now, because everybody is at risk, really, if you look at the risk factors for osteoporosis.
Yeah, I asked that question assuming the answer was like a lot earlier than most people would probably consider, but most of the people who are our customers, probably your customers, our listeners, they have kids, so they can pass along that information to their kids and sort of, relay the fact that the earlier you start, the better. And it is interesting to know, like the frame that I've always used to think about sort of muscle mass and bone density, I guess, is you kind of climb to a certain point, and you were saying that's in your 20s, I suppose. And then I think in your 30s for muscle, it's really hard to build a ton of new muscle beyond that. And then from there, it's basically a fight to hang on to what you have. That's how I've always thought of it. It's like build, and then you're just all your work after that is just fighting to hang on to what you have. That's the frame I've always used for it.
That's a great way to look at it. And you're right, muscle mass, it comes after. And I think for my guys, I'll tell them, because I have a lot of patients in their 40s and 50s, sort of in the other side of my practice for health optimization. And I'm telling those men, look, if you're in your 40s and 50s, you get as muscular as you can, right? Because once you kind of like peak in your 50s, if you're working really hard, it's a downhill slide, and you got to fight every day to slow it down. So yeah, same thing. Learn what your starting point is. It's just easier to see with muscle.
Sure, and it's definitely worth reiterating the fact that it's definitely possible if you're in 40s and 50s to put on muscle mass, and that should be a goal for most people in this country. I think this country is very under muscled, is probably the best way to put it. So it's definitely possible. It's never too late to start. I feel like a lot of people can go sort of a lifetime without exercising. They're like, why bother? Why now? And it can make a massive difference starting in your 40s or 50s.
Yep.
So you mentioned diet, like childhood diet. Can you just talk about the influence of diet kind of growing up? And it sort of spins my head off into, I wonder if there's even like really early childhood considerations, like duration of breastfeeding, birth delivery method. I bet is there any research around like those types of things that have considerations to long-term bone density?
Yeah, it's interesting. I haven't seen it go back to delivery method. But it's, you could argue, right? Like if you underwent a C-section and that was your welcome into this world was a, quote unquote non-traumatic, although I don't know if you've seen a C-section, but it's still not the same as going through the birth canal. It's going to put you in a different starting place. But no, I've not seen any research on that. But definitely your eating and activities through childhood and adolescence will play a major role in your peak bone density development. Yeah, absolutely. If you look at even like gymnasts, and you could argue, you mentioned about diet. So this is a group that obviously struggles with adequate nutrition in some spaces, but the way that they are active and the impact that they impart on their bone density in general is really good. So then let's take your, female gamer who has a poor diet. Like, what's her bone mineral density like? It's terrible. And so then there's genetic factors associated with that too. But absolutely, because I have a 4-year-old, right? So I watch her and I'm looking at her diet and I'm thinking, okay, how do I get more protein in her? And is she getting adequate minerals and nutrients? Because if I don't know if you have kids, but man, it's really tough to feed kids good food. I have a 4, 9, and 11-year-old, and they're all in different stages of challenging eating.
So what are the considerations that you mentioned? If you what are these boxes that you're trying to check from a nutritional standpoint? If you can just rattle off some of those.
Yeah. Number one being adequate protein. And this is the first thing we do when somebody enters into the program is we have them track food and we figure out how much protein they're eating. And across the board, without fail, they're all protein deficient. That's almost changed a little bit because people are coming in by listening to my YouTube channel. And so they've heard me say this, I don't know how many times. So now they're coming in, they're like, no, it's a gram per pound. I promise. I'm eating a gram per pound, but they just started that. So that's the number one thing, because you have to have adequate protein to build muscle, adequate protein to build bone. right? Bone is 50% protein by mass. So that's the number one thing. And then the second thing is going to be, honestly, in this group, this is different from the rest of the population, but in the bone health group, it is really adequate nutrition just overall. They tend to be a nutrient depleted group for whatever reason, again, chicken or the egg. So just making sure that they're getting enough calories and that those calories are coming from good food sources. So those are the kind of the two big things out of the gate.
Okay. You said it, but can you just give us like, what is your protein threshold that people should be eating?
So 1 gram, I said it really fast, 1 gram per pound of desired body weight. And so for this bone health group, actually, generally, we're pushing that upwards of their actual body weight. Of course, if you're talking about a weight loss group, it's going to be lower, but so 1 gram per pound of desired body weight is sort of our starting point. And then obviously we have to take into consideration, do they have kidney disease and what other issues, but that's the general starting point that we're going to aim for people.
Okay. Very helpful. And then, I'm assuming you do sort of lifestyle assessments. Do you check how much people are walking? How do you sort of judge their levels of daily physical activity, if you will?
Yeah, so we have questionnaires on questionnaires. Onboarding into our program is let's just call it work, because we have to get a lot of information, and they're meeting with coaches, and so sometimes this takes multiple visits, but pretty quickly we can identify where people are falling short in the activity side. A lot of people will wear trackers. We don't mandate it. I love it when people will wear something like a Whoop or even an Apple Watch, something where we can get a sense of how active they are. But ultimately what we're looking for is how much resistance training are you doing? How heavy of things are you moving around? Are you doing any kind of impact training? Are you just getting out and moving? And those are sort of the basic fundamentals. And then of course we dive into like the rabbit holes of all the different modalities and things that people can do.
Yep. All right. So I come from a personal training background, so let's dive into resistance training. Do you have like a minimum days per week that you want people to be doing? Do you have a standard split that you start people on for people who have never exercised before?
Yeah, this is the tough thing, right? So, obviously there's a massive range of ability level coming in, and we struggled with this early on because I just didn't have a tool that I could apply to. I have high level athletes in one side, and then I have people that literally just don't get off the couch on the other. So how do you train that whole group through a telehealth platform? And I didn't have the answer to that. But now we have created a couple of different things. So we have some of our patients will work with some videos made by Rebecca Rothstein, who founded a company called Buff Bones. And so these are very specific to bone health and to fall prevention, and they're really great foundational videos, and they're Pilates based. And so that's an opportunity that we have for people, and that's easy because anybody can pretty much do that. And then we have another level up, and this is a level that we've recently created. And Nick Truby, who is a PhD in exercise physiology and runs a training program, a virtual training program, he now will meet with our patients and do an initial consultation with them and kind of figure out what their starting point is. And now we have content and different starting tracks. So we'll say, look, this is your starting point, this is your track, and then we just program them from there. And then, of course, they have follow-up coaching. So they're just going to continue to kind of march down this programming pathway. That's just launched recently, though, so too early to say, how we're doing with that. But I would say in general, we're kind of hitting, I would love to see people do 3 to 4 days of resistance training a week if their body can tolerate that. And that's way more than most of this age group is doing it.
For sure. I was thrilled to get people who were relatively active to, if they were training with me 2 days a week, to get them to do 2 additional days per week. That was a big ask for a lot of people. So yeah, I think 3 to 4 days a week is an ambitious goal for most people, but I think also attainable. Can you speak to how sleep affects your bone health? Sleep affects everything. I'm assuming there's a big influence on it. I'm guessing it sounds largely like you subscribe to like the biopsychosocial model, where there's a lot of things. It's not just purely the food you're putting in your body and the exercise, but like stress and environmental factors are going to play a big role in your overall health, and bone health is going to be a part of that. So is sleep a factor?
Absolutely. Yeah. So if we define our framework, we kind of have 2 different versions, but the framework that includes sleep is, how do we reverse bone loss? And the answer to that is you have to start with the foundation. And that foundation is nutrition, exercise, sleep, and then connection, and can dig into that. But the sleep part is critical. And as I'm sure you know from working with people, that if they're not sleeping, it doesn't matter how good anything else is, right? Nothing's going to work. They just feel terrible. So yeah, sleep's really important. And what's really interesting in this group is that I find that they really struggle with sleep. And I think that there's so much fear and anxiety with having osteoporosis and not having the security to know that you can do an activity and not have a fracture. They're just sort of lying in wait of this like impending doom, that's out there. And it's a pretty crappy way to live. So a lot of these patients, they have that, kind of difficulty falling asleep, ruminating thoughts, wake up at 3 a.m. with elevated cortisol. Like we have to battle those things. So it definitely plays a role in bone health, because we know that chronic inflammation, chronic cortisol, and then this cortisol is going to impact how you eat. All of those things are directly tied to how well you sleep.
Yep. Sleep is definitely one of those, has like a very cascading effect, positive and negative. When you're sleeping a lot better, everything else just seems easier. You're going to be more motivated to exercise, eat better. And the same is true on the opposite side as well.
Right.
Yeah. So you're talking about sort of the connection side of things. Can you speak to that? I have a framework of like 6 pillars of things that people should be doing. And one of them is, healthy relationships. I'm assuming that's what you were speaking to as forms of connection.
So I've struggled and I've renamed this pillar, I don't know how many times.
Yeah.
So it started out as stress mitigation, because stress is important, right? And then I realized it's not just stress, really underneath stress is in my opinion, for a lot of people, it's spiritual health, right? Like, do you have something that you have faith in, that you can believe in, that, there's a bigger, a greater, a whatever, right? Doesn't matter what it is, religious or not, but some kind of spiritual connection. But then that's not really it either. And then I've kind of come to this idea of connection, because it's connecting with source, with God, with people, with your community, with your children, with my dog. Like it's all of these things that can help to really keep us strong and keep us moving forward and having purpose. So I've renamed it recently connection. So that's what I mean.
That seems like a very good catch-all bucket to throw those into. Mm-hmm. Yeah, I personally have healthy relationships in one bucket and then stress mitigation in another. So it's 2 sides of the same coin for sure.
Yeah, just more pillars.
Yeah. How do you introduce people to that if you feel like they don't have a great support system, or it's all very inwardly focused and there's not that sort of something greater than themselves to work towards? Do you have any idea or tricks to?
Yeah. So, I mean, the hardest thing is just even bringing it up, and so the way that our program works, they meet with the coaching team first, and then I come in after they've met with the coaching team. And sometimes this has been pieced out already. Sometimes people, they just come out with it. They're like, this is the thing. But I always kind of go through the pillars and see what people connect with. And a lot of times these patients are coming in, they're a lot really dialed in, I'm doing this exercise and my diet's like this. And I'm like, cool. And then I ask them about, well, tell me about your spiritual health. And I phrase it in different ways depending on the person. And a lot of times people are like, oh, dialed, right? Like I have a meditation thing and I pray and I do this and awesome. But a lot of times people will say, I don't do anything, like they don't have an answer, and then like, oh, okay, well, this is probably a weak point. And I have found if you can dial everything else in, and if that piece is truly missing, they're going to falter. They're just not going to be able to thrive. And so then the question, and I don't know the answer to this, but the question is then what do you do about that? Because that's really hard with the tools that I have available, that's really hard to do something with.
Yeah, it's similar to sleep in that if you're not addressing a way to mitigate stress, and if you don't have those healthy relationships, it's a very challenging thing to duplicate elsewhere. Like it's hard to just ramp up these other pillars that we're talking about to just fill in the gap for that. Yeah, that's a tough nut to crack for sure.
Yeah. I have ideas, so I'm exploring some things, but I don't have an answer yet.
Yeah, well, it's good. It's a very worthwhile problem to work on solving. Yeah. Can we go back to sleep for a second? Do you have any sleep hygiene tips or tricks or tools that there's so much out there, but you've probably had to distill it down to something somewhat reasonable just you see people repetitively. So what do you do for people who aren't sleeping particularly well?
Yeah. In general, I kind of kick this to my coaches because they have the accountability side. But when that's their thing and I have time in our meeting to discuss it, then I start with, what leads up to sleep. And it's almost like your entire day, right? It's almost like we need to plan from the beginning of the day when we're going to go to sleep and how we're going to get there. I really like the framework that Craig Ballantyne uses. I don't know if you've heard this 10-3-2-1 rule. So make sure I can get this out right. So the 10-3-2-1 rule is 10 hours before bedtime, no caffeine. 3 hours before bedtime, no food. 2 hours before bedtime, no work. 1 hour before bedtime, no screens. Right. And so I like it because it's not so rigid that you can't follow it. You know, some people will say like, turn off your lights and wear red glasses and like, blah, blah, you know, it's like, wow, like I don't live in a cave. But I like it because you can still live your life. Like you can have dinner at, you know, like let's say you have dinner at 6 and then your bedtime is, you know, between 9 and 10. And then you can, you know, hang out with your kids and you can even potentially watch a little TV, although I'm not a huge advocate of that. But you wind things down and then you have that hour of truly winding down. No work, no screens, truly unplugged, connecting with your spouse if that's an opportunity that you have. And then you're getting yourself into bed and really like preparing yourself to launch into sleep. You know, and then you're setting the stage of, you know, what does your sleep chamber look like? And, you know, do you have a TV in there? And do you have other lights in there? And like, it's such a big deal, like to have a cold, dark sleep chamber, you know, and it's critical. And I see crazy stuff that people are like, I have this like merry-go-round in my bedroom. Like, what are you doing in there? And so I think those are the biggest things out of the gate. And then we have to figure out like, okay, well, where are your struggles, you know, and is it the 2 a.m. wake up and is this a cortisol thing? And then you can really start diving in. But that's the biggest thing out of the gate is just setting your bedtime, being absolutely consistent, both weekdays and weekends, and sticking to it and having the right sleep hygiene to get there.
This is something I go back and forth on all the time. Also, first, I want to mention how much I like that you refer to it as a sleep chamber and not a bedroom. It's just like such a good way to reframe it to get people to think of the importance around sleep, which they should.
Right.
Is there like a good comparison between like diabetes and pre-diabetes and osteoporosis and osteopenia? Because like a lot of these can be just terms, and like if people aren't wildly involved in the healthcare space, you can be like, it's just a term. It's a term I've heard.
Yeah. I mean, gosh, there's a lot of discussion around like even the word osteoporosis and like, why is it defined the way it's defined? And how did we come up with this T-score thing based off of DEXA? So let me just dig into that a little bit. The short answer to your question is yes, there's a thing and it's called osteopenia. And I wish I had like a whiteboard behind me, I'd like draw this out. But basically what happens as we age predictably, although arguably doesn't have to happen this way, but this is what happens, is that our bone mineral density, like we said, is your peak bone mineral density is in your early adulthood, right? Early 20s to 30s, and it starts to decline in your 40s reliably in everybody. Then when you see the chart that this is what, when you get a DEXA score or in a DEXA scan, this is the screening imaging for osteoporosis, you'll see this chart. And the chart, it has age on the bottom, and then it has T-score, and I'll define that in a minute on the vertical side. And then you can see that the average T-score will drop over time, right? And so the T-score is a statistical analysis of bone density compared to that of a early 20-year-old in your same gender and ethnicity. So, you know, for me, it would be a Caucasian guy, me now compared to where I was in my 20s. And there isn't a lot of difference because I'm in my mid 40s. But as you age, it starts to drop down. On either side of that average, there is a kind of a shaded bar. And within one standard deviation, so we can talk about statistics, but within one standard deviation is quote unquote normal. Between -1 and -2.5 standard deviations is osteopenia, and then less than -2.5 is osteoporosis. Now, those numbers were relatively arbitrarily chosen not that long ago. And so we created this definition of osteoporosis based off of the statistical analysis of an imaging study that was adopted. Trying to remember, but I think it was like late 90s. So not that long ago. And there's a lot of, I hear suspicion around, you know, this, like, it was the drug companies and they had the drugs and they wanted to make a diagnosis that fit with the, you know, and like, I'm like, I don't know if that's true, because it does also coincide with fracture risk. So it's interesting. So yeah, there is a thing, and how important is that thing? Like I said, like I technically have osteopenia. Am I worried about fracture risk? Not at all. And you have to understand too, like as you age, osteopenia is normal. arguably, I'd love to see it not happen, but it's still normal. And I see people, I see women in their 60s and 70s, and they get diagnosed with osteopenia, which is not an ICD code. There is no diagnosis of osteopenia. And they're freaking out, right? And they're scared of fracture. And it's frustrating because that is totally unnecessary fear and anxiety, because it's totally normal and they are probably not at risk of fracture. And yet we kind of instill this fear of this thing called osteopenia, which is actually normal deviation from average bone mineral density.
Okay. Yeah, I appreciate you explaining that. It's just kind of giving people an idea that this is something that is on a spectrum. So it's not just a binary, this or that. There's a long spectrum. And then, as you said, there's nuance to it as well. Even if you fall on somewhere in the spectrum where there's this word osteopenia, if you have the expertise or you have a provider with the expertise, they can tell you whether or not it is or is not a concern.
Hopefully, yeah. And let me just say one more thing about that is that osteopenia can be a problem depending on how early you are with it and what your trajectory looks like. So if you were barely osteopenic, 2 years ago, and now you're severely osteopenic, almost osteoporotic, like that is a big problem, right? So I wouldn't say like, don't worry about osteopenia, but it's a delta thing. What's the difference from one test to another? Another reason to get tested early.
Which is such a great point. Like that's where the nuance and the context comes in. So is your average primary care provider going to be well-versed in this? Are they even testing for it? And you mentioned before what the test is for. Can you explain a little bit what a DEXA is? So I think it's important for people to be their own best advocates, to understand like what is the test I should maybe be asking for if it's not standard.
Yeah. So the standard test is DEXA. It's available worldwide and easily accessed in pretty much any community. So it's around. So we have to use it because it's there. The downside of DEXA is a few big ones. And one of them is that it's only measuring one aspect of bone strength. And what we want to know is how strong are your bones and what is your risk of fracture. DEXA is essentially an X-ray. So all it's measuring is the body's ability or the skeleton's ability to absorb or not absorb X-rays. And that's all based on mineral density. That's why we call it bone mineral density. It's what it tells you. But it doesn't tell you about bone strength. And there are several examples where you could point out that improvement in bone mineral density does not necessarily improve fracture risk, and vice versa. You can see improved fracture risk with some therapies that don't improve bone mineral density. So we know that there's a whole other side to this thing. But DEXA is globally available, so we use it, right? It's there. So there are a couple other ways to measure it. We can answer those in a separate question, but that's what a DEXA is.
Okay. Yeah, that's a good explanation. On a very personal note, I've been getting DEXA scans for years. I hate the way they print out. Do you use your own printouts, or do you plug in the data that you care about into a certain chart? Or do you actually
I pretty much just look at a few points.
Okay.
Yeah, you've probably been doing them also for body comp, I would assume, right?
Yeah.
Yeah. So some of the body comp DEXAs don't even give a T-score.
Right.
So it's kind of like, it's challenging when people say, I got this DEXA, can you take a look? And it's like, oh, well, I can tell you what your, visceral adiposity is, but I can't tell you what your T-score is. So you do have to find the right one. And that can be a challenge for us too, because again, we're telehealth nationwide. So I don't know all the providers.
Yep. Yeah. Just for years, I'm like, this is a useless printout, largely speaking. I just use an Excel sheet and kind of plug in the things that I care about.
Right.
So yeah, if you could kind of explain the other ways to measure, the other metrics that you look at to sort of get a more well-rounded view of not just bone mineral density, as you've been talking about through DEXA.
There's three things to talk about. So some people will talk about this thing called TBS, or trabecular bone score, and this goes with a DEXA. So DEXA is the traditional thing. You can have a kind of a software add-on called TBS. It, in theory, will look at bone quality. Personally, I'm not real impressed with what that data actually provides me. I don't really know how to interpret it, and it's not because I haven't read about it. It just doesn't really seem to make a lot of sense to me. It also has the downside of being manipulated by arthritis and deformity, and so it doesn't give me a lot of good information. The one that I really like, if people have access to it, is a ultrasound study called REMS. And REMS is an ultrasound, like I said, and so there's no radiation. And it gives you both bone density and T-score, but it also gives you a fragility score. So it tells you what your bone architecture is like, and it's pretty solid. It's been studied compared to DEXA, and there is some differentiation or difference between the two. I would argue that probably REMS is likely better, but once something has been labeled as the gold standard, you can't say that something is better or worse. You can only say that it's different. So we don't really know. The downside of REMS is that it's just not globally available. There's just not a lot of them out there. And then the last thing that we do for understanding what's happening with bone metabolism is actually to look at biomarkers. So not even doing imaging, just saying what's happening with your osteoclasts, what's happening with your osteoblasts. And there are bone turnover biomarkers that we can get in blood, and they're great. So I can tell you, are your osteoclasts slowing down? Are your osteoblasts building up? What does our ratio look like? What does our metabolism look like? And that's really what I'm looking at. More so than imaging. I care what happens to your DEXA, but I more care what happens to your bone turnover biomarkers as we go.
Interesting. So what are the tests for that? The biomarker tests.
So the acronyms are CTX, and that's C-telopeptide, and that's the osteoclast or bone breakdown test. And then the other one is P1NP, which stands for pro-collagen type 1, pro something, P1NP. There you go. And it actually is listed. It's different no matter where you look at it. But anyway, P1NP is the bone building osteoblasts biomarker. So they change relatively slowly. So you can get this nice trend over time, and we could really see big changes with therapy in a couple of months, rather than saying like, oh, well, you have to wait 2 years to do a DEXA to see a difference, and then wondering like, did the DEXA actually show me what I think it showed me? So the bone biomarkers are way better for short-term progression.
Yeah, I think that's great, and also very important in that I think a lot of the interventions and like measurement protocols within the space they're just kind of slow. So I love like a more iterative process where you can be like, all right, well, these are the interventions I prescribed. I can see their adherence or not, and then see whether or not, based on these blood tests, whether or not things are moving in the right direction or not. It's just it creates a faster feedback loop, which I think is much needed in healthcare.
Yeah. And it just provides that the feedback that what you're doing is working, right? And I see people just get such fatigue because it takes so long to see improvements in DEXA.
Yeah. I can imagine that's very frustrating for something that's not even the complete view anyway.
Right.
So I kind of glossed over this, but I want to go back to it. Are these things that your general primary care is going to be able to identify or know about, or are they going to refer out to specialists?
So it's kind of a challenging answer. So most primary care doctors, internists, obviously they know about the disease. They have a plan, but that plan is generally going to be based off of pharmaceuticals. And this is where I see so much contention in the patient population because their expectations were not met by their doctor. I see it doesn't matter if it's primary care, internist, endocrinology, whatever. But you have to remember, if I'm talking to the patients, to say that the medical system is what it is, right? We have a medical system that is designed around diagnose and treat. And that treatment is going to be whatever we can do to achieve our goal in the least amount of time possible. And that's generally going to be pharmaceuticals. So I see patients frustrated to say, well, my doctor didn't even talk to me about nutrition and exercise and stress management and sleep and supplements and peptides and hormone. I'm like, well, they had 7 minutes. Like, how are they going to have that conversation? And so I think the expectations are unfortunately just off. And our system is not good at treating things that require a comprehensive lifestyle solution, right? Like this is diabetes, this is dementia prevention, this is cardiovascular prevention, right? These things our system is not good at preventing. It's good at not dementia, but cardiovascular. If you have a heart attack, man, you can get stented in under like 60 minutes. That's amazing, right? Like, you're in a car accident and you have a trauma and you could be in the surgery, you could be in the OR getting fixed up in less than an hour. Like that is phenomenal care. But is it phenomenal to throw a bisphosphonate drug at somebody who's perimenopausal with osteoporosis that just barely has it and doesn't have any other workup? I don't think so, So yeah, they have a tool, they have an approach, but it's not an approach that I would probably agree with.
Okay. Yeah, no, I think it's just great for people it's just helpful for people to be able to have this information so they can better navigate the healthcare system, even if it is just what it is, exactly like you said. But it is worth saying, like you mentioned, we're awesome at trauma in this country. I don't want to get in an accident in any other country but this one. We're very good at that.
That's right. Preventing
things is, that's the next step.
It's just a totally different approach.
Mm-hmm. Yeah, for sure. So I'd love to kind of go into your company now. And now that we have a bit of a framework around what this is and also a pretty good understanding of like the healthcare industry as you just described it, I'd love to see like where you fit in and sort of like
how also your background as to how you ended up here. I think it was a great line to saying like, you're trying to teach people about the things to prevent people from getting the surgeries that you were constantly doing. So if you could just explain a bit more about your company and your background, I think that'd be a great place to go.
Yeah, well, let me just start with how I got here, which is I'm an orthopedic surgeon by training. So I'm board certified in orthopedic surgery. I did that for 7 years in practice before I finally jumped ship. And I treated fragility fractures. So that's hip fractures, and that's, wrist fractures, and all the stuff that comes along that needs to be fixed. In that practice, I was continuously frustrated by the lack of care that my patients could get in things like osteoporosis, but also the other things like, diabetes was another one that just drove me bonkers. And so you're right, I was doing the fragility fracture work, but in the diabetic patients, I was cutting off legs, and I'm talking to these patients and saying, look, diabetes doesn't even need to be a disease, right? This is a nutrition problem, and it can totally be put into remission. This doesn't have to happen. But they weren't there to hear me talk about that. So after watching my wife, who is in the nutrition space, totally turn people around, and I was seeing this opportunity to help people to optimize their health rather than just do surgery, I decided to start making some moves. So I did a second fellowship and got board certified in anti-aging and regenerative medicine. That fellowship was in functional medicine. Did some more training in hormones, and then started part-time, started the health optimization side part-time to sort of like get my feet wet, and just loved it, and then sort of the pandemic happened, and we were like, well, telehealth doesn't sound so bad right now. And so that was sort of my impetus actually to make this leap. Very early on in that health optimization practice, I realized that what we were doing was perfect for bone health. And that the model that we had created with our health optimization pyramid that I kind of described earlier was the way that you slow down and potentially reverse bone loss and reverse osteoporosis. So we started kind of reaching out to people that we had some of those patients coming to see me because they knew me from fixing their fractures. So we kind of tested it out, and it was awesome. We're like, wow, this is amazing. So we started trying to message both messages in one platform, and it was just sloppy and ugly. And so we ended up creating a second company. So now we have the optimal human health side, and we have the optimal bone health side. The YouTube channel is Optimal Bone Health with Dr. Doug. And that's where we're putting so much energy and effort there to help educate, because we kind of have two missions. One is to provide amazing patient care, but the other is just to educate globally. And YouTube is the platform to do that. And so started doing this on a bigger scale. Now over half of our patients are all patients with osteoporosis. And we use this framework called the 4R framework that I haven't really mentioned yet. And the 4R framework is just to recognize why we're losing bone, reverse those causes of bone loss, retest to make sure you're headed in the right direction, and then to revive your life and live without the fear of fracture. That, just putting that out there like that, speaks so much to the people that are just searching for the answer, because they are desperate a lot of times. There's so much fear around having this thing. Their doctor told them to take this drug and they don't want to. Now their doctor's going to break up with them. They're like bullying them into taking drugs. And it's just so unnecessary. And the way that I look at osteoporosis is that if caught early enough, it really is reversible in most people. There are circumstances where bone loss is going to happen, things like cancer treatment and, chronic steroids and stuff like that. But for most women and men, this can be reversed, and somebody can be put on the path to really have no issues with osteoporosis and fragility fracture.
That's great. I think people should be hugely optimistic about that. And I want to kind of go back to your point of like how tragic it is that people live in fear of like not being able to live their lives in the way they want to. So this goes back to a question that I wanted to ask earlier, which is about exercise. Did you find a lot of people were avoiding exercise because they were worried their body couldn't handle
totally.
it?
The recommendations from their doctors were so counterintuitive and conflicting, because they would say, you need to do resistance training, take calcium, vitamin D, and take this drug, right? And they'd be like, oh, and don't lift anything more than 3 pounds. I'm like, wait, what? So I'm going to do resistance training with a 3-pound dumbbell. Yeah, so they just don't know. And honestly, it is hard. And I put this on Nick, our exercise guy, and I'm like, hey, look, man, you're making the call here. Like, how much can they lift? It's really hard to know, but the truth is you start low, you go slow, and you build up, and you'll get stronger. Your bones will get stronger. Will somebody probably fracture at some point doing an exercise that my team told them to do? probably, right? But we're pushing in the right direction, and we're doing everything we can to put people on the path that's going to get them there safely.
Mm-hmm. And to think about the cost of not doing exercise. So that's usually
Absolutely.
That's always how I frame it.
Because you're not going to build bone without it, right? And this is where I see people like, people that are taking the drugs, and they take these anabolic drugs like Forteo and Tymlos they're cool, and they're tools that we do use occasionally. But even then, like, you've got to have the right diet. You've got to supplement with the right things if you're not getting it through diet, and you still need to stress your bones. Like, you're not, if you just take the drug, it's going to do something, but it's not going to do nearly as much as if you feed your metabolism what it needs.
Yeah. So you can't do it without resistance training, and you can't do it without adequate protein intake, right?
That's right.
You need the building blocks to be able to build
right.
what
you got to stress the bones. The bones are like every other tissue in the body. They respond to stress. The more you stress them, the more they'll grow.
Yep. And that just happens in the training world. So it's progressive overload, where you just start at something manageable, stress it to a certain point, let the body adapt, stress it more, let the body adapt, yada, yada, yada. That's all of personal training in a nutshell right there. So what sort of model, like financial model, do you guys operate in? Are you sort of concierge? Do you accept insurance? Do you accept health savings accounts, flexible savings accounts? Anything you can share about that, just so people know sort of the resources that are available through your company?
Yeah, so this has been a challenge because the care that we offer, I mean, I've kind of described it a little bit, but I'll just say it's awesome, right? Like, this is how, when I was in practice in the traditional medical model, this is how I wanted to treat people, right? Like, you bring them in, you take care of them, you answer their questions in a timely manner, you treat them like people, you provide them with coaches, you help them with accountability, you order the stuff that's hard for them to get on their own for them, and you have it delivered to their house, right? Like, this is how I want to be taken care of. The problem with that is it's expensive, right? Like, that's a tough team to run. And so we have our full service program, which is what I just described. And the price is going to vary depending on where you're coming in and what you're coming in for. But what we've been really trying to do is to find that, like, what's the next level down that provides people with as much as we can in a very cost efficient manner. So what we've come up with, which we're launching in mid-August, I don't know when this will come out, but we're going to launch our beta program mid-August, and it's going to be a group coaching. So group coaching is not going to have physician interaction, but it'll give people access to all of the video training that we have. So we have an entire library of educational videos. Give them access to the physical training, either through Nick Truby or through Buff Bones. It'll give them access to our coaches. It'll give them access to, how to get all the tests done and kind of guide them through that. So, like, these are the tests. This is how you get them. This is how you interpret them, right? So kind of like a little bit of self-service. You'll have coaching calls, live calls from my PA, and then access to all the training, the nutritional guides, and et cetera. So it is a program that I think most people would likely be able to do the majority of the work themselves. And then those that want that next level service, we'll be there for that. But the demand is so big right now that I can't get more people in at this point. So we need to be able to bring people in and have a group coaching model where it's going to help the people that don't need as much help.
Yeah, no, that's really smart. I think it's a really clever model. And by the time this comes out, that will be available. Awesome. So also, before I forget, we're going to link to your website. We're also going to link to your YouTube channel in the show notes, just because largely the purpose of this podcast is to provide people with just all these different avenues of education, and me finding people who are reliable sources of that information. So that'll definitely be available. I'd like to know, like, what your thoughts are on sort of the future of healthcare, because obviously you're doing something where you moved out of the traditional model of healthcare, and you described it perfectly. Like, you created a business where you can treat people the way you want to. I think that needs to happen more, but it is happening in this it's always cash pay. I'd love to hear your thoughts on where you think the industry is going, if direct primary care is going to be a very viable model in the future, anything like that.
Yeah. Are you familiar with Peter Attia? Do you know that author? Yeah. So I love the way that Peter kind of puts it in his book. If people haven't read it, Outlive is awesome.
I'll link to that as well.
Yeah. I view how we should take care of health span very similarly as he does. I love one of the things he talks about in there very extensively is this idea of a new medical system, and he calls it medicine 3.0. with 2.0 being the system that we're in now, and 1.0 being the system that preceded ours, preceded pharmaceuticals and used like bloodletting and stuff. And so we're in, our traditional model is 2.0, and he sees this 3.0, and he sees the way that I imagine that he treats patients and the way that I treat patients as how we will be able to treat everybody. I think that's amazing. I am not that optimistic though. And the reason why is because, as I just said, to have the team in place to do the work that I want to be able to do for people requires two important things. One is resources, because I got to pay my team. But the other is the patient has to care. And while I'm very fortunate that my patients are all, they're self-selected, right? So they're paying cash, they're coming to me like they want to get better. But I very clearly remember when I was in practice, like I mentioned, the diabetic patients who I would tell them, like, this is the secret, like you can reverse diabetes and put it into remission. And they look at me like I have two heads because I'm talking about what to eat. We have to remember that, us in this like health and wellness space, most of the people listening probably are interested in getting better and will likely do something to actually do that. But most of the population is not like that. And most of the population doesn't really want me to tell them how to work out or how to live their life, or, not to binge watch Netflix before they go to bed and to get their TV out of their room. Like they don't want to hear that. So while I would love for Medicine 3.0 to exist, I'm not optimistic that that's the future. I think the future probably is more something along the lines of 2.0 just sort of continues to do what 2.0 does. And we have this service, and I think it will likely eventually become globally available so that there will be no lack of resources for people. But the quality of care is going to continue to come down. And we're going to have to start drawing a line in the sand, because the system will go bankrupt if we continue to offer the things that we're offering at the way that they are continuing to increase in cost. And so I think we're going to see a system that sort of devolves into a base level of care, and then a new system that you can buy into. And that new system is going to probably have a different type of insurance, right? Be like an insurance company that does cover what I do, right? But the people that are buying into that insurance are paying, I don't know if they could be higher premiums than what I pay for my current insurance, but you know what I mean? Like it's going to be a different tier of care, and how that all happens, I have absolutely no idea.
Yeah. It's arguably one of the most complicated problems in our country. It's certainly the most financially burdensome, but
sure.
Do you see, you're describing that sort of base level of care. Do you see that being in like a single payer system?
Yeah, I do.
Okay. So you think that's the direction we're going?
I do.
For better or worse?
What are the worse?
What are the drawbacks?
Yeah, I mean, so the drawbacks are, so I have friends in Canada and Britain, and it's interesting. So now this YouTube channel, which is really taken off with worldwide comments. So I'm getting comments and stories about people all over the world. So we have a big Australian, Canadian, I have a Netherlands contingent. I don't know why. And so I get these stories about healthcare across the world, and it's really interesting. And what I hear is the systems that have a single payer system, they don't have access. Like they can't get the tests. So this is an amazing thing. So if you have a worldwide audience, people are going to start flying to Asheville, North Carolina to see me, get a blood draw, do the functional test, have a consultation, right? And then we can do a follow-up once they're home, because they just don't have access to the stuff that we have access to here. So that's the drawback. There's just very little further development in pushing the needle on it. And they just don't have access. And if they do, the waiting time is so long that it's very difficult to get care. But if you have an accident, you don't pay anything, right? If you get sick, you don't have to worry about it, right? And we pay almost $3,000 a month in insurance premiums I have a healthy family that doesn't need care, right? That's insane. And so, yeah, I don't know what the answer is.
Yeah, neither do I. I think single payer systems are incorrectly hailed as some sort of panacea, but it only solves like the problem of negotiation. You get a lot more negotiating power
right,
with the payers, but yeah, the access problem is a real one. It's a very real one. I know in Canada, in one of the places up there, they tried capping how much physicians could make, and then so it was like by like September, right, in a calendar year. By
sure.
September, every doctor was on vacation. They're like,
right.
they hit their cap, and then
Well,
access.
they would move to the U.S. They all
Right.
got U.S. licenses and would come
Right.
practice in the
Yep.
U.S. So I know several surgeons, they would cap their procedure number. And so they would hit their procedure number and it'd be like middle of the year. And they're like, well, I'm going to go to the U.S. and do, they come do cash pay practices or do whatever, right? Come here, do research or, so yeah, it's really tough.
Yeah, it's hard to know the answer. And you look at these models around the world, like you said, there's benefits and drawbacks. What's the Australian model, if you happen to know?
I don't know off the top of my head.
Yeah.
I would not want to speak incorrectly.
Yeah, no worries. One of the things I want to go back to is about sleep. This is the question that I was trying to figure out how to phrase. Do you guys have like different tracks of thinking around, like there's different sleep problems, right? There's sleeping through the night. There's waking up with cortisol in the middle of the night. There is trouble falling asleep. So you have like different tracks, be like, based on this particular problem, I'm going to take them down like this set of protocols.
Yeah. So, we definitely would treat people differently that have those there's three clear things, right? It's like my sleep onset's terrible, right? It takes me 2 hours to fall asleep. And then there's the middle, there's the 2 to 3 a.m. cortisol. And then there's I'm waking up at 4 a.m. And so, yeah, they all require different modalities, potentially even different, supplements or potentially even pharmaceuticals, right? For people that truly have insomnia. And I'm not an insomnia specialist, but we go down this pathway and I'm as aggressive as I need to be because like we said earlier, it's one of the foundational things. If you can't figure this out, then you're not going to be successful.
Yep. Yeah. Definitely got to figure out a way to address it one way or the other. Do you think anything around AI is interesting, or do you have any like interesting technologies you're seeing in the space where you're like, maybe this will help people at scale. This will help me be more efficient in my practice. Anything you're excited about from sort of a technology standpoint?
Yeah, I'm excited about AI from educational perspective. So AI content, and I play with ChatGPT, and I use it. I don't have none of my content is AI created, but I'll create stuff through AI, and I'll kind of like proof it. And I'm sort of in this in between mode where I'm thinking, gosh, there is a way that I could leverage AI and educate people faster for cheaper, right? And I'm a little concerned about what the content is sometimes. Like I still want to read it all. So I'm definitely the limiter there. But I think there's certainly a role for that. There's a role in blogs and audio content and even creating potentially like scripts for me in the future, like just because it does such a great job of putting it together. I wrote a book. We should mention my book. I wrote a book that's coming out and will actually not be out yet. Maybe I think our launch date is September 18th. I would plug some of these things into AI and look at what it would print out, and I'm like, man, it's not bad, right? Like it's not bad. So I think there's definitely a space for this. I haven't figured out the right way to use it for us yet, but it is a tool that I think a lot of people could use too. And this is almost something that when I get all these questions on YouTube, I almost want to tell people like, stick that into ChatGPT, like, and you're going to get a pretty good answer. Like you can train it to you can actually train it to talk like me if you want to. And so, I think there's definitely going to be a role for that in the future, but I don't think it's going to supersede the expertise of opinion and somebody who's been able to sort of figure their way out of the weeds of the research and kind of come up with their own plan. Because if you ask AI how to treat osteoporosis, for example, it'll tell you to take drugs. Ask AI, what the right diet is, and it'll give you an answer that I don't agree with. Put it that way.
Okay. Yeah. So, I mean, yeah, it's definitely a promising area, but I think it's just going to be, at least in the near term, I think it's going to be people like you who are learning how to leverage it to increase their output in education. Because like you said, do you have very little faith in medicine 3.0 happening? I don't necessarily disagree. I think it's going to be driven by the needs of the public. And like you said, most of the people who are listening to something like this, they're already sort of on the healthier end of the spectrum, but maybe the YouTube algorithm will accidentally push this to somebody who meant to be watching something else and will get them hooked. But that's just the hope that you have to have with these things. So getting towards the end of this, I do want to wrap up. Is there something that you, like if you were a ruler for a day and you could just make anything happen in this country, like what would you want to implement to make the country healthier in a very collective manner?
Yeah, I think the biggest underserved thing in our country, and probably worldwide, but our country for sure, is just getting outside and doing some kind of activity. Like I think if we all got out in the morning and got some kind of, UV exposure in the morning and did some kind of activity that we found enjoyable, I think that the whole world would be a much, much better place.
Mm-hmm. I've kind of joked for a few years with my co-founder, where I was like, if we can get the collective people on our platform to, on average, walk 8,500 steps a day, I'm like, I think we're going to win health.
Yeah, totally.
It's like, it's very simple things like that. So getting sunlight, walking. I think it's a great
message. It's so under leveraged by so many people.
Yeah, exactly. And it's like, it's free. It's very accessible.
Right.
We talk about social determinants of health, like walking. I understand there are unsafe neighborhoods, but it's a different conversation.
Right.
The last thing I want to ask you is, like, if you couldn't have been a physician, surgeon, entrepreneur, what else could you see yourself doing in this world? I know I just crossed off a lot of things.
Yeah, no, that's good. So actually, when I was making this transition out of orthopedics, I had days where I didn't know if this was going to work out. And so I was asking myself that question, like, what would I do? Like, if I didn't have to work, what would I do? If I didn't have to make money, what would I do? And honestly, I think the answer would probably be farming.
That's really interesting.
I have 9 acres. I have chickens out there. I was like, I'm gonna get some goats. I'm gonna get some cows. I'm just gonna start raising food.
I'm really jealous. I grew up in New Jersey, so there was always farm fresh eggs available. Now I live out in Scottsdale.
So good.
Yeah, no, I bet it's awesome having your own eggs right on your farm there.
Yeah,
that's a great answer. Yeah, farming.
Yeah,
that's a really good answer.
I still might do that someday.
Yeah, no, it'd probably be incredibly gratifying, and just force yourself into that sort of daily activity and a very strict routine. I don't think people, because I kind of grew up working on farms, so it's just like the animals just force a routine on you in like a very pleasant way.
Yeah, no, it's great.
I think it's sort of a lost art in this country. So I guess the last thing I'll ask, also, this will be out after your book is released too, so we'll link to that as well if you can provide me that link.
The book is out. Well, I'll give you the link. Yeah, it's not, we don't have a link right now, but just in case we don't, it's called The Osteoporosis Breakthrough: The Natural Way to Reverse Bone Loss and Build Stronger Bone.
Wonderful.
There you
go. The last thing I want to say before I kind of get your closing thoughts is that I think it's easy for people to get overwhelmed with talking about all these lifestyle factors, having to manage nutrition and daily activity and exercise and sleep and relationships and connection. But the good news is this was all in conversation related to bone health. And the good news is, like, if you do those things, you're checking a lot of boxes for pretty much everything else. Metabolic disease states, diabetes, heart disease. So it may seem overwhelming that I'm kind of always having these conversations around specific disease states, but it's the lifestyle factors are, if the overlap were a Venn diagram, it would be a circle. Right. It's so much. It's so much of the same things. So I'd love to just get your closing thoughts. Anything else you just want to share before I let you go?
Yes. I mean, I think in this space, the most important thing is to be an advocate for your health, but don't stick your head in the sand. And what I mean by that is so many patients, as I mentioned earlier, they get scared by the diagnosis of osteoporosis and they go to their doctor and their doctor says, hey, you should take this drug. And then the initial fear is predominantly global about these drugs for good reason for some of them. But here's where I think people really get stuck is that they don't want to do it, or they do it and they don't want to do it and then they stop doing it. But then they don't keep going, or they don't take the drugs and then they look up, they're like, oh, well, I'll take this, this one supplement, right? But then I'm not going to change anything else. So you have to be an advocate for yourself. And if you don't want to take the drugs, explain that to your healthcare provider. And if they then give you this like guilt trip, then you have to find somebody that can help you create a comprehensive plan. It doesn't have to be me, but there are other people out there that can help you through all the lifestyle stuff, the custom supplements, talk about hormone optimization and the risks and benefits. And if you're a candidate for that, consider peptide therapy, which is awesome for, muscle mass and will indirectly impact your bone. There are so many tools out there. Just don't stop. Keep being an advocate for yourself. Retest if it's blood test, if it's DEXA, if it's whatever, but have a game plan and just like knock it down. Just keep going.
That's great. Yeah, I really appreciate you sharing that. And that's kind of one of the common messages I'm getting from a lot of people that's been on the show. Like, a lot of the questions end up sort of ragging on the healthcare industry. And it's like, this isn't great, this is inefficient, but we still live in a place with a ton of resources. So we are in a very resource-rich country. There are plenty of options available, and people do need to be their own best advocates and just trying to find the right combinations of providers and practitioners and people surrounding them to get them to optimal health. So this has been a really fun conversation for me. Dr. Doug, I really appreciate you coming on and sharing your knowledge. And again, we're going to link to a lot of the resources we mentioned in the show. And I really appreciate you being here.
Yeah, awesome. Thanks so much for your time. This was great.
Hey everyone, that's all for today's show. I want to thank you so much for stopping by and watching, especially if you've made it all the way to this point. If you'd like to be notified when new episodes are going to be released, feel free to subscribe and make sure you hit the bell button as well. To learn more about today's guest, feel free to look in the description. You can also visit the podcast website, which is exploringhealthpodcast.com. That website will also be linked in the description. As always, likes, shares, comments are a huge help to me and to this channel and to the show. So any of that you can do, I would really appreciate. And again, thank you so much for watching, and I'll see you next time.